Imagine going into the hospital for a necessary, truly life-improving abdominal surgery.
Right.
Like maybe it's a colorectal procedure to remove a tumor or an operation to finally treat severe inflammatory bowel disease.
Yeah, a major surgery.
Exactly. So you go to sleep, the surgery's a success, the cancer or the disease is gone, and you wake up immensely relieved.
As you would be.
Right. But as you recover over the next few weeks and months, you slowly start to realize that, well, something else is wrong.
Something they didn't really warn you about.
Yeah. Your bladder control is completely different. Or you notice that your sexual function, your ability to feel arousal or reach orgasm has just completely vanished. And you have absolutely no idea why.
Yeah, it's a terrifying scenario. And unfortunately, it's just far more common than most people realize.
Which is wild.
It is. Because when we talk about abdominal and pelvic surgeries, the focus is almost entirely on the organs themselves, right?
The colon, the rectum, the bladder.
Exactly. But surrounding those organs is this highly vulnerable, microscopic world that often gets, well, entirely overlooked in the broader conversation about surgical recovery.
And that microscopic world is our mission today.
Mm-hmm.
We are going to map out the hidden electrical grid of the human pelvis.
It's such a complex grid, too.
It really is. Specifically, we're looking at how a pelvic sympathetic nerve injury, which is, often a completely unintended byproduct of previous colorectal surgeries, can drastically alter a person's entire quality of life.
Absolutely.
To do this, we've got a really fascinating stack of sources for this deep dive. We're pulling from dense anatomical encyclopedias, clinical surgical audits, physical therapy blogs, and we're even deep diving into reproductive health guides, like the cycle tracking app Clue.
What's fascinating here is that we have this deeply ingrained habit of thinking about our bodily systems in, isolated silos.
Right.
We assume that digestive system is over here, the reproductive system is over there, and the urinary system is just in its own little corner.
Just doing its own thing.
Exactly. But this research proves just how intimately and honestly, sometimes precariously, they're all wired together.
Okay, let's unpack this blueprint of the pelvis, because before we can understand how this grid goes down during a surgery, we really need to understand how this hidden anatomical machinery normally works.
Right, the baseline.
Yeah. Give us the lay of the land. What exactly is this electrical grid?
So in medical terms, we're talking about the pelvic autonomic nervous system, or PANS.
PANS, okay.
Yeah, PANS. This is the background operating system of your pelvis. It controls the things you don't actively think about, and it's essentially divided into two opposing but complementary forces, the sympathetic nerves and the parasympathetic nerves.
And the sources divide them into two very distinct operational modes, right?
They do. So the sympathetic nerves, which include structures like the superior hypogastric plexus and the hypergastric nerves, are primarily responsible for what we can call storage and emission.
Storage and emission.
Think of the sympathetic system as the dam holding back a reservoir.
Okay, I like that analogy.
These nerves tell your bladder muscle to relax so it can actually expand and fill up with urine while simultaneously contracting your internal sphincters to keep the gates closed and keep you continent.
So it's actively holding things in.
Exactly. And in terms of sexual function, they manage the physical emissions. So like ejaculation in men or the rhythmic orgasmic contractions in women, as well as, returning blood flow to normal after arousal.
Okay, so sympathetic is building the dam, holding the tension, and managing the controlled release.
You got it.
What about the parasympathetic side?
The parasympathetic nerves, which originate lower down from the sacral spinal roots, they handle the exact opposite, emptying and arousal.
Okay.
If the sympathetic system is the dam, the parasympathetic system is blowing the floodgates wide open.
So they're the ones saying, let it flow.
Exactly. These are the signals that tell the bladder to actively contract so you can pee. And sexually, they drive physical arousal.
Right.
They trigger erections, clitoral engorgement, and that intense vascular swelling that produces vaginal lubrication.
And these two systems, the sympathetic and the parasympathetic, they don't just run parallel to each other down your spine. They actually weave together at this one critical junction.
Yes, a very busy junction.
The inferior hypogastric plexus, or the IHP. The anatomical texts actually describe this as the control tower of the pelvis.
It's an incredibly dense meshwork. You have the sympathetic lines coming down from the abdomen and the parasympathetic nerves coming out of the lower spine, tangling together into this, dense triangular web right next to the major plumbing.
The rectum and the bladder.
Exactly.
But there is a specific anatomical quirk about the sympathetic lines coming into that junction. specifically the superior hypogastric plexus, that completely changes the surgical reality, doesn't it?
It does, and it's a detail that really highlights the complexity of human anatomy.
It's wild.
Because you would assume a major nerve plexus runs straight down the absolute center of the body, tracing the spine, right?
Right, like perfectly symmetrical.
Right, but cadaveric studies show that the superior hypogastric plexus is rarely perfectly centered. In almost 58.8% of people, it actually deviates to the left.
Almost 60% of the time.
Yeah, and it's not a single predictable cord either. Sometimes it spreads out into a wide net, sometimes it splits into two parallel bands.
Wow.
So for a surgeon operating in that space, it is an asymmetrical, highly unpredictable structure.
Which begs the question, if this anatomy is so delicate and so unpredictable, what happens when a surgeon has to go in there and remove a tumor from the colon?
That's where things get complicated.
Right. Let's look at colorectal surgeries, procedures for severe inflammatory bowel disease or rectal cancer. Where are the actual danger zones in these procedures?
Well, the danger lies in the geometry of the human pelvis. It is essentially a rigid bony funnel, and in men, it is particularly narrow.
Just less room to work with?
Exactly. When a surgeon is performing a total mesorectal excision, which means they are trying to remove the rectum along with the entire fatty envelope of tissue and lymph nodes surrounding it, they have to navigate incredibly tight margins.
Because they have to ensure they get all the cancer.
Right. And sympathetic nerve damage often happens high up in the abdomen when the surgeon is ligating or tying off the main blood vessel that feeds the lower gut, called the inferior mesenteric artery.
Okay.
Or it happens slightly lower, right at the pelvic brim, where those left-leaning sympathetic nerves are just hanging out.
Wait, hold on. I have to challenge this premise a bit, though.
Sure.
If those nerves are that crucial to a person's basic bodily functions, shouldn't surgeons prioritize sparing them? Or is this a situation where the surgeon's priority is purely getting the cancer out, and the nerves are just accepted as unavoidable collateral damage to save the patient's life?
It's really a combination of both. It's the sheer priority of removing the malignancy, yes, but also the physical reality of what these nerves look like.
What do you mean?
You have to picture this environment. These nerve fibers are microscopic. They are virtually translucent.
Translucent.
Yeah. They don't look like distinct wires. They blend in completely seamlessly with layers of connective tissue and fascia.
Oh, wow.
Add in inflammation, maybe prior radiation damage or active bleeding, and they become practically invisible to the naked eye.
And the surgical reviews point out that the damage isn't always a direct, careless cut with a scalpel, right?
Yeah.
The mechanisms of injury are far more insidious.
Direct transection does happen, but more often, the injury is from traction.
Traction, like stretching.
Exactly. This means the nerves get stretched beyond their elastic limit when the surrounding tissues are pulled back to get a better view of a tumor.
Ouch.
Or the injury comes from thermal spread.
Which is heat.
Right. Surgeons rely on advanced tools that use intense heat to seal blood vessels and cut through tissue simultaneously. And even if the heated tool never physically touches the nerve itself,
The heat still reaches it.
yes, the thermal energy can radiate outward. That heat denatures the proteins in the nerve's protective myelin sheath, which essentially short-circuits the nerve without ever physically cutting it.
And without specialized nerve-sparing techniques, the historical rates of urinary and sexual dysfunction after these surgeries were staggering. I mean, anywhere from 30% to 70% of patients experience major functional loss.
That's a huge portion of patients.
It is. So if a surgeon is operating in that blind spot and the heat from a tool accidentally denatures the myelin sheath of that sympathetic nerve, what does that actually look like for the patient when they wake up? Let's start with the sympathetic injury symptoms in men.
Okay, so a classic symptom of sympathetic nerve damage in men is retrograde ejaculation.
Okay, break that down for us.
Going back to our earlier analogy, the sympathetic nerves are responsible for emission and closing the dam.
Right.
They contract the internal bladder sphincter to keep the upward pathway closed.
Oh.
If those nerves are short-circuited, that sphincter stays open during orgasm.
Oh, I see.
So instead of the semen being propelled outward, it takes the path of least resistance, which is backward into the bladder.
Wow.
It's not physically dangerous, but obviously it causes significant distress, major fertility issues.
Now, here's where it gets really interesting, especially when we look at the female symptoms, because it brings us to the data from the Reproductive Health app, Clue.
Yes, the Clue data is so illuminating here.
Right. They provide this breakdown of vaginal fluids, and we really need to clearly distinguish between two different biological mechanisms here: cervical fluid An arousal fluid.
It is a vital distinction, and honestly one that is often misunderstood.
Yeah.
Cervical fluid is essentially mucus. It changes consistency throughout the menstrual cycle in response to hormones, becoming, slippery around ovulation to help sperm survive.
So it's hormonal.
Yes, that baseline lubrication happens regardless of whether someone is sexually aroused.
But arousal fluid operates on a completely different mechanical system.
Exactly.
The Clue article explains that when physical sexual arousal begins, the parasympathetic nerves trigger intense blood flow to the genitals. This vascular engorgement creates immense localized pressure.
Like a sponge filling up.
Right. And that pressure forces a fluid called a transidate directly through the vaginal walls. It's almost like a plasma sweating through the tissue.
That's a great way to picture it.
Now, if we tie that mechanism back to the surgical nerve damage we were just talking about.
Well, if the parasympathetic nerves are damaged, the body cannot achieve that initial vascular engorgement.
So no pressure.
Meaning no genital swelling, no pressure, and no transudate fluid.
And if it's the sympathetic side?
If the sympathetic nerves are damaged, it specifically impairs the ongoing vaginal lubrication and blunts the actual physical sensation of the orgasmic contractions.
Imagine the profound confusion of this experience for a patient.
Oh, absolutely.
I mean, think about it. You are in a loving relationship. You are mentally and emotionally completely turned on, but your body is flat out refusing to produce arousal fluid or physical swelling simply because a translucent microscopic nerve was stretched by a retractor during a colon surgery 6 months ago.
Yeah.
The disconnect between your brain and your body would just be so isolating.
Deeply isolating. And so much of this functional fallout is internalized.
People blame themselves, right?
Exactly. People naturally assume it's a failing on their part. They think they've mysteriously lost their libido, or they assume it's a purely psychological issue, maybe a relationship problem.
Right, because why would they connect it to their gut?
Precisely. Unless someone explicitly tells them, they rarely connect an inability to lubricate back to a healed scar on their abdomen.
Which brings up a huge point.
Yeah.
If the mechanical failure is this severe and this life-altering, are patients being told about this risk before they consent to the surgery?
The short answer is frequently, no.
Let's look at the data on this. There's a 2-year clinical audit from the University Hospital of North Staffordshire in the UK.
Yeah, the UK audit.
So we looked at 118 patients who underwent elective colorectal surgery involving deep pelvic dissection. Overall, only 36% of those patients had documented informed consent regarding the risk of pelvic nerve injury.
Just over a third.
Nearly 2/3 of people were completely in the dark. But the overall number isn't even the most startling part. When you break that data down by gender, the audit reveals that 51% of the men were explicitly consented for the risk of sexual dysfunction. For the women, only 5%.
It is a massive statistical disparity.
Are we really saying that just because female anatomy is complex, we skip telling them they might lose their ability to orgasm from a bowel surgery? Is this just a case of individual surgeons forgetting to mention it? Or is there an underlying systemic reason in the medical literature for this gap?
This raises an important question about medical vulnerability and how data shapes care, because the authors of the audit delve into exactly that. Historically, surgical literature and postoperative studies have focused heavily on male erectile dysfunction.
Because it's obvious.
Right. It's a very visible, easily quantifiable mechanical failure with well-established pharmaceutical treatments.
Viagra, things like that.
Exactly. Female sexual arousal pathways, on the other hand, are structurally more diffuse and have historically been incredibly under-researched in surgical outcomes.
Wow.
Because female sexual dysfunction after bowel surgery wasn't rigorously standardized or measured in the legacy literature, it essentially became an out-of-sight, out-of-mind scenario when it came to drafting procedure-specific consent forms.
Like the old adage, if you don't measure it, it doesn't exist.
Exactly. And the study highlights that this isn't necessarily malicious intent by individual doctors, it's a systemic blind spot.
Right, they're using the forms they have.
Yes. It exposes an urgent need to update procedure-specific consent forms so they force a mandatory conversation, ensuring that female sexual health is given the exact same preventative weight as male sexual health before anyone goes under anesthesia.
Absolutely. And, the complications of pelvic surgery don't even stop at the autonomic nervous system.
No, I don't.
Even if a surgeon is incredibly skilled and perfectly spares the sympathetic and parasympathetic nerves we've been talking about, the procedure itself can compromise an entirely different type of nerve. the pudendal nerve.
Ah, yes. The pudendal nerve operates differently. It is a somatic nerve,
Meaning what exactly?
meaning it carries sensory and motor signals that you actively feel and control. It branches off the lower spine and travels deep through the pelvis, passing through a highly constricted, bony tunnel called Alcock's Canal.
Okay, Alcock's Canal.
Right. And its job is to supply direct physical sensation to the clitoris, penis, vulva, perineum, and rectum.
So when this nerve gets compressed, whether from surgical positioning, postoperative scar tissue, or even just chronic sittings, you get a condition called pudendal neuralgia.
Yes.
The sources describe it as a nightmare of neuropathic pain, burning, shooting, electric shocks in the genitals.
Yeah.
But the specific symptoms are so bizarre, I mean, you would question your own sanity if you experienced them.
You really would. Neuropathic pain rarely follows conventional logic because the nerve itself is malfunctioning. It's not a normal injury.
Right.
And one of the most striking diagnostic symptoms is a phenomenon called allotriesthesia.
The golf ball phenomenon.
Yes.
Explain the mechanism behind this because it's fascinating.
So allotriesthesia is the intense, persistent physical sensation that a foreign object, most commonly described as a golf ball or a tennis ball, is lodged deep inside the rectum or the vagina.
But there's nothing there.
Physically, there is absolutely nothing there. It is a continuous neurological misfire. Because the pudendal nerve is being physically crushed or inflamed inside that narrow Alcock's canal, it sends an erroneous, looping signal of extreme pressure to the brain.
And the brain just misinterprets it.
The brain interprets that localized nerve compression as a large physical object occupying the pelvic space.
I mean, trying to explain a phantom golf ball to a doctor who isn't well-versed in nerve entrapment must be incredibly frustrating for a patient.
It's often misdiagnosed for years.
I can imagine. And then there's the positional nature of the pain. The literature constantly references the toilet seat relief diagnostic. What is happening mechanically there?
This is such a clear indicator. People suffering from pudendal neuralgia often find sitting on a normal flat chair to be absolute agony. The pain spikes within minutes.
Okay.
But bizarrely, sitting on a toilet seat provides almost instant relief.
Why?
Mechanically, it comes down to weight distribution. When you sit on a flat surface, your perineum bears a significant amount of your upper body weight, which presses directly against that inflamed pudendal nerve. Right. But when you sit on a toilet seat, the hole in the center means your perineum and pelvic floor are suspended in the air.
Ah.
Your body weight is completely supported by your ischial tuberosities, your sit bones. It instantly removes the physical compression from the nerve pathway.
It's a remarkably specific diagnostic clue. And it's worth noting that while our focus is on colorectal surgery today, the physical therapy sources emphasize that this exact same pudendal nerve entrapment can happen from non-surgical trauma too.
Oh, absolutely.
Childbirth, chronic constipation, or even just years of cycling can compress the nerve. In fact, sports medicine often refers to it as cyclist syndrome.
Precisely. Any activity or trauma that causes prolonged pressure, severe stretching, or the formation of dense scar tissue in that region can compromise Alcock's Canal and trap the nerve.
Well, we've painted a pretty grim picture so far of hidden surgical minefields, denatured nerves, missing consent forms, and phantom golf balls.
It sounds bleak.
It does. But the intention here is not to leave you in despair. Let's eliminate the dark. If someone is facing a biresection tomorrow, what are the actual modern tools preventing this from happening?
Fortunately, the medical technology intervening here is advancing rapidly, particularly in the realm of preoperative imaging.
Okay, how so?
To solve the problem of these microscopic nerves being invisible, surgeons are now utilizing high-resolution 3T MRI combined with diffusion tensor imaging, or DTI, before they ever make an incision.
Now, how does DTI actually map a nerve it can't traditionally see?
DTI is brilliant. It tracks the natural movement or diffusion of water molecules in the body.
Water molecule.
Yeah. In a nerve fiber, water molecules don't move randomly. They move linearly, flowing along the long axis of the nerve tract.
Oh, like a microscopic river.
Exactly. The DTI software tracks this linear water movement and uses it to draw a highly accurate three-dimensional topographical map of a patient's unique nerve layout.
So they can see the quirk.
Yes. The surgeon can literally look at a screen and see exactly where that 59% left-leaning nerve bundle is located in that specific patient before the surgery even begins.
That is incredible. So that handles the pre-op planning. But during the surgery itself, how do they avoid the thermal spread and the traction in real time?
Intraoperatively, the frontier is near-infrared, or NIR fluorescence imaging.
Fluorescence.
Yeah. During the procedure, anesthesiologists can intravenously inject specific contrast agents like indocyanine green.
Okay.
This dye travels through the bloodstream and binds to specific tissue proteins in the autonomic nerves. Then the surgeon operates using a special camera that emits near-infrared light.
Or that happens.
Under that specific wavelength, those normally invisible translucent nerves literally glow a bright fluorescent green on the surgeon's monitor.
They turn the hidden electrical grid into a glowing map.
Exactly. And when you combine real-time glowing nerves with robotic-assisted surgery, which filters out human hand tremors and provides microscopic precision, the outcomes change dramatically.
By how much?
The historical rates of major urinary and sexual dysfunction drop from that 30 to 70% range all the way down to 10 to 30%.
Wow, that is a massive reduction in collateral damage.
It's life-changing.
It really is. But what if a listener falls into that remaining 10 to 30%? Or what if someone listening has already had a pelvic surgery and is dealing with this neuropathic pain or dysfunction right now? The physical therapy sources are emphatic that there are highly effective interventions post-surgery.
Yes, and that is crucial to understand. Unless a nerve was completely severed, which is rare, there is a high potential for recovery.
That's good news.
If a nerve is bruised, stretched, or trapped by surrounding tissue, specialized pelvic floor physical therapy is often the first and most effective line of defense.
And the physical therapy blogs talk extensively about treating something called pelvic floor tension myalgia.
Right.
Explain how the muscles actually perpetuate the nerve injury there.
Well, when you experience pelvic pain or surgical trauma, your body's involuntary defense mechanism is to guard the area by clenching the surrounding muscles.
Like tensing up when you're hurt.
Exactly. But that constant clenching creates a vice grip. The spasming muscles further crush the pudendal nerve, which causes more pain, which causes more clenching.
Ah, so it's a vicious self-sustaining cycle.
Exactly. A skilled pelvic floor physical therapist works internally to manually release those spasming muscles, gently break up minor scar tissue, and physically decompress the nerve pathway.
And what if manual release isn't enough to break the cycle?
In more severe, persistent cases, pain specialists can utilize targeted nerve blocks.
How's that work?
Using ultrasound guidance, they inject a combination of a local anesthetic and a corticosteroid directly into Alcock's canal.
Right at the source.
Yes. The anesthetic immediately stops the nerve from firing those erroneous pain signals, providing instant relief. Meanwhile, the steroid works over the next few weeks to drastically reduce the localized inflammation and physical swelling of the tissue that is crushing the nerve, giving it the physical space it needs to heal.
So what does this all mean? We have navigated the hidden electrical substation of the autonomic nerves, examined the microscopic dangers of thermal spread in colorectal surgery, unpacked the systemic failures of medical consent, and explored the incredible mechanics of glowing nerves and pelvic floor therapy.
If we connect this to the bigger picture, it proves that the human body adamantly refuses to operate in isolated departments.
It's all connected.
The pelvic region is a highly intricate, densely packed ecosystem. A procedure designed strictly to heal your digestive system can, and frequently does, profoundly alter your urinary and sexual health.
Which means knowledge is your best defense.
Yeah.
Understanding that this hidden electrical grid exists empowers you. If you or a loved one are ever facing a pelvic or abdominal procedure, you now have the specific vocabulary to advocate for yourself.
That's the most important takeaway.
Right. You can ask your surgeon about diffusion tensor imaging. You can ask if they utilize near-infrared fluorescence. You can demand thorough, procedure-specific consent that actively addresses your sexual health, regardless of your gender or the historical biases in medical literature.
Refuse the siloed view of medicine. The successful removal of a disease is paramount, yes, but your quality of life and functional health post-surgery matter just as much.
I want to leave you with a final lingering thought to mull over today. We've explored just how subtle these injuries can be: a minor traction stretch, a localized bit of thermal spread, a microscopic web of scar tissue. If our anatomical wiring is truly this sensitive and intertwined, where a minor internal scar from a digestive surgery can completely shut down physical sexual arousal or create mysterious neuropathic pain months later.
Yeah.
How many people are out there right now silently struggling? How many people are sitting in therapists' offices believing they have a psychological sexual dysfunction or agonizing over a failing relationship when it might actually be an undiagnosed microscopic nerve injury from a past physical trauma?
It is a profound question, and one that perfectly underscores why we need a much more holistic, integrated approach to understanding human health.
The hidden grid is always running. Until next time, keep diving deep.